Namaskar. Greetings to everyone. Welcome to the M-Norm Talk Show, an initiative where we talk about the developments and treatments of diabetes. I am your host, Pavni Panya, and today, to educate us more on this topic, we have with us India's renowned endocrinologist with us, Dr. Subhash Kumar Wangnoo. Currently, Dr. Subhash Kumar Wangnoo is working as a senior consultant in endocrinology and diabetes at Indraprasth Apollo Hospital, New Delhi. Welcome to our show, Dr. Subhash.
Thank you, Pavni.
So, before we get into our questions, we are very curious to know a lot of things from you, Doctor. A lot of knowledge we want to gain from you. But before that, I think we would love to know a bit about you, about your journey in the medicine line, and overall, why did you choose endocrinology? And any special or memorable case do you want to share with us? So, a bit about your journey.
Absolutely. My main interest in endocrinology came when my mother was diagnosed with diabetes when I just entered into the MBBS undergraduation. After that, the endocrinology became a passion for me, and I did my MBBS, followed immediately by MD and my super specialty training, that is DM endocrinology, in the same go. You know, I'm having more than 40 years of experience of endocrinology practice.
Oh, wow.
And when I came to Delhi, there was hardly any endocrinologist in practice. Only there were two endocrinologists in the leading institutions like All India Institute of Medical Sciences. But in practice, I was the first endocrinologist in Delhi.
That's amazing.
So that is my passion. It has become a passion. I still work 12 to 14 hours every day, and I will continue to work till I am capable of doing that.
Wow, doctor, that is absolutely beautiful. 40 plus years of experience. So, we are a bit curious to know from you, out of these whole 40 years of experience, any memorable case that you want to share?
Absolutely. I can't forget even today when a young lady, 26 years old, came to the emergency department of the Apollo Hospital with a sugar of 400. And she was about to get married next day. Imagine, she's going to get married next day, and day before she came to the emergency hospital with a sugar of 400, and she was a little bit drowsy. You know, the parents were in shock. All the relatives were crying. I told them, look here, she will get married tomorrow, and I challenge, it's 6 o'clock right now. By 12 midnight, she'll be absolutely okay and she'll be back to her home. So that was the case because I started very aggressive treatment. We gave a lot of fluids. We gave insulin directly into the blood to control the blood sugars. And by midnight, her sugars came down to 140, 160. She was feeling good. She went back to her home. And thank God she got married next year. And she came to me after marriage, thanking Doc, I am okay now. And she is still following with me, and she is a mother of 2 kids now.
That's absolutely lovely.
So that is one case I can't forget in my life.
That is so heartful to hear. That is amazing. That's why we call that doctors are next to God, almost life-saving. That is beautiful. Thank you so much for sharing that. Okay, I think we are ready to dive into our questions and get to know more about diabetes and its treatment from the expert, of course. So, my first question to you, doctor, is that what are the second generation of anti-diabetic drugs?
So let me explain. Don't call it second generation. It is better to call them what are the newly launched anti-diabetic drugs.
Okay.
Because they're different class of drugs. So every class has got second generation drugs. So we call it newly launched or the latest generation of the anti-diabetic drugs. Among them, the most important are the what we call the gliptins, which came before the another class of drug, which is called SGLT2 inhibitors. like empagliflozin, dapagliflozin, and canagliflozin. And after that, these SGLT2 inhibitors, then came the recent introduction of GLP-1 receptor agonist therapy. This is again equivalent to the recently launched the SGLT2 inhibitors in the term that they are important for the weight loss, they are important for the sugar control, and also they are cardio-renal protective. That means they protect you from the deadly complication of the heart and the kidneys.
Okay. So, doctor, out of these, or in general, which is the newest class of anti-diabetic medicine?
Of course, the newest class of anti-diabetic medicine, which has been launched recently, about a couple of weeks back, is called GLP-1 receptor agonist, which is important for the treatment of diabetes, in particular those who are obese, and it helps them to reduce weight, reduce the fatty liver, reduce the sugar values, protect them from the heart and the kidney problems, and it has got multiple pleiotropic effect. Pleiotropic effect means apart from controlling blood sugar, it has many added advantages. And close to that, this GLP-1 receptor agonist, I think you might have heard in the newspaper everywhere from the horse's mouth, the wonder drug Ozempic and the Mounjaro people are taking right and left to lose weight and to become smart,
Yes.
lean and thin. And close to that is the SGLT2 inhibitors, what we call the empagliflozin and the dapagliflozins. Both are in the same race for the diabetes as well as the weight loss as well as the cardio-renal protection. So both are almost going parallel to each other.
Okay. So you told us about SGLT2 inhibitors right now. So I want to understand that what is their primary mechanism of action?
You know, as the name implies, SGLT2 inhibitors means sodium glucose transporter 2 inhibitors. They basically act because these receptors for the sodium glucose transporter SGLT2 are in the proximal tubule of the kidneys. Proximal tubule of the kidneys, and their main function is to reabsorb glucose when the patient passes. It reabsorbs glucose and throws into the blood. Means it causes the whatever the glucose is filtered in the urine, it gets reabsorbed in the blood. So there's nil excretion of glucose in the urine in the normal person. What happens in the diabetics? There's small amount of glucose which is spilled into the urine. Because when the blood sugar threshold goes above 180, the sugar gets spilled into the urine. The scientists thought, why not? We develop a drug which causes increased excretion of glucose through the urine so that the blood glucose becomes less. So based on this premise or based on this fact, they developed these drugs called SGLT2 inhibitors. What they do, they inhibit the receptors on the proximal convoluted tubule in the kidney, and because of that the glucose is not reabsorbed into the blood and it gets spilled over into the urine. That means there is excess of glucose in the urine so that the less amount of glucose goes into the blood. So this is called glucosuric effect of the SGLT2 inhibitors. Apart from spilling glucose into the urine, it also causes uric acid excretion and the increased delivery of the sodium. Sodium is an ion to the distal convoluted tubule. Because that has got many advantages. When there is an increased delivery of the sodium to the distal convoluted tubule, what happens? That there is some, in layman terms, I would say hemodynamic changes. Kidney has a glomerulus with a lot of arteries going inside. They filter the blood and the toxic substances are gone into the urine. So what happens? It changes the hemodynamics of the arteries which are going and arteries going out from the glomerulus, so that there is increase in the intraglomerular pressure, and it causes increase in the filtration rate. So that is a improvement in diabetes. When the glomerular filtration rate goes, it causes increase in the filtration rate, and simultaneously it also inhibits the protein excretion from the urine, what you call the proteinuria. So in a nutshell, in short, for a common person to know, the SGLT2 inhibitor have a unique mode of action on the proximal convoluted tubule to inhibit the receptors and to cause glucose to pass into the urine, glucosuric effect, uric acid also passes, and also increase excretion of sodium and delivery of sodium into the distal convoluted tubule, what in turn we call the tubuloglomerular feedback mechanism. And this mechanism, TGF, is the mainstay of the mechanism of action to prevent the progression of the kidney damage in diabetic patient by preventing the excretion of the protein in the urine, that is diabetic nephropathy, and maintaining the GFR, glomerular filtration rate.
Wow, that was a lot of knowledge, doctor. That's amazing. So, previously you talked about these SGLT2 inhibitors, empagliflozin and
Dapagliflozin.
dapagliflozin. So, what is exactly the difference between them two? Please tell us.
So let the people also know they are not only the two SGLT2 inhibitors. Apart from the empagliflozin and the dapagliflozin, there are canagliflozin and sotagliflozin.
Okay.
The canagliflozin, empagliflozin, and the dapagliflozin, they are available in our country, but the sotagliflozin is not yet available in our country. Now, the EMPA and the dapagliflozin, these are two drugs which are commonly prescribed by the medical professional. But to me, the canagliflozin, dapagliflozin, empagliflozin are on the same board as regard to the reduction in the blood sugar in terms of the reduction in the HbA1c, in terms of the weight loss, how much weight they causes over the long run, and also in terms of the renal protection.
Wow, doctor. So, we got to know about so many gliflozins right now. So, what exactly is the difference between all of them?
Excellent question. As I was already discussing that among all the three gliflozins, canagliflozins, empagliflozin, and dapagliflozin, as regard to their efficacy means their potency to reduce the blood sugar, and which is measured by the HbA1c. This is almost same in all the three gliflozins. Then second important action, their ability to cause weight loss over the long run, that is also same among all the gliflozins. Number third, the difference comes basically into the cardio-renal protection effect. So you might have heard that when these group of molecules came into the market, there was a huge, enthusiasm among the medical profession. The first trial which came was the EMPA-REC trial, which taught us that the empagliflozin protects heart in terms of cardiac mortality, in terms of the what you call the reduction in the 3-point MACE. 3-point MACE is basically ki angina attack, coronary artery disease, heart failure. So EMPA-REC was a huge success in the sense that all the doctors started writing this drug for the prevention of the cardiac events in diabetic patients. In fact, the prescription came more from the cardiologist rather than from the endocrinologist. Then came another important trial, which was regarding the dapagliflozin. That was a DAPA heart failure trial. Now, this was the EMPA-REC trial, which told us about the good effect on the cardiovascular complication. When the DAPA heart failure came, it was mainly devoted to the patient to know whether the introduction of the dapagliflozin at the proper time reduces the incidence of hospitalization for heart failure in the near future. So it was such a wonderful trial, and it showed that it significantly reduces the incidence of the hospitalization for the heart failure. And there we were all, there's an eye opener for all of us that there's a new drug which also prevent the development of the heart failure in diabetic patients. Initially, we had empagliflozin for the overall cardiac reduction in the cardiac mortality and 3-point MACE. Then came the dapagliflozin for preventing the occurrence of heart failure in the near future. So these two molecules, the trial came side by side and simultaneously, one after the another. Then came what you call the DAPA CKD trial, because they had already shown that dapagliflozin was cardioprotective, means it protects your heart from the heart failure as well as from the heart disease like myocardial infarction, stroke, or angina. When the DAPA kidney came, for the first time, it showed that dapagliflozin also prevents the progression of the diabetic kidney disease. Means it will prevent the progression of the protein leak in the urine, what you call the proteinuria, and it will also improve the GFR, the glomerular filtration rate. So again, the people started, and initially when the Emperor came, the cardiologists were writing more empagliflozin than the endocrinologists. When the DAPA CKD came, nephrologists, the kidney specialists, started writing dapagliflozin more than the endocrinologist because it protected your kidney. After some time, the empagliflozin group, the manufacturer, they started another trial called the EMPA kidney. After DAPA kidney, they also wanted to show that empagliflozin is also superior. When they brought out the trial result, the EMPA kidney, wow, it was shown that it also prevents the progression of the chronic kidney disease or the diabetic kidney disease. And this drug can be used even when the patient's GFR, the glomerular filtration rate, is even less than 20. Normally, when the DAPA CKD came, the cutoff is that if the GFR goes below 30, you cannot use this drug. But when the EMPA trial came, they again further showed that you can use this drug even when the GFR is as low as 20. So see, these are, is not a war. This is for the benefit of the patient. When some new molecules come, is for the benefit of the patients. So these are some of the newer innovation which really has helped the millions of patients to improve from the clutches of the heart disease, heart failure, and the chronic kidney disease or the diabetic kidney disease.
Okay. So, in the context of the kidney protection, which of these gliflozins would you recommend, doctor, as a senior consultant in endocrinology? So, yes, please shed some light on it.
It's sort of a diplomatic question. But I will tell you, definitely with the evidence based, not only is it my opinion as what is the evidence in the literature. Obviously, I will prefer a molecule, empagliflozin, because it can be given with the GFR as low as below 20, because the product insert in the dapagliflozin says that you cannot use this molecule when the GFR goes below 30. So I have the advantage of using this drug even with the GFR goes less than 20. And number two, apart from this kidney protection, nowadays we call it a holistic approach of protecting the not only the kidneys but the heart. We call CRM approach, cardio-renal metabolic protection in patient or diabetes. So you are right. As a senior endocrinologist, my preference will be with the empagliflozin because in real sense, there is no need to modify the doses of the empagliflozin, whatever the kidney function may be there. At all levels of the kidney function, the empagliflozin can be used safely without any fear, while with some other gliflozin which might have to be a little bit more cautious, but absolutely this is a most safest molecule as regard to the kidney protection.
So that is coming out of 40 plus years of experience. We can definitely trust on that. Okay, so doctor, you talked about CRM, cardio-renal metabolic. So we did talk about the kidney protection. Now I want to know from you about the cardiovascular disease. Which of these inhibitors are better in protection of the cardiovascular disease, especially in type 2 diabetes patients?
A good question again. So initially I told you something about the EMPA-REC trial, which was really a beautiful trial, primarily made to focus on the cardiac protection. So when I see the comparison between the EMPA and the dapagliflozin, dapagliflozin basically came with the heart failure protection. The cardiac protection in terms of, we call it 3-point MACE or the total cardiac mortality benefit. DAPA was more focusing on the heart failure rather than seeing the 3-point MACE and the overall mortality reduction. The empagliflozin was the only molecule where I could see the EMPA-REC trial that there was a mortality benefit. So that is one important point when I see that there is a mortality benefit. So ideally and preferably, I will be happy to use a molecule when you have got a mortality benefit apart from the other parameters, what is normally the usually indicator of the cardiovascular disease. So depending upon the science and the trial, definitely my choice will become that EMPA-REC trial has shown a good cardiac mortality benefit, so I'll still prefer to use empagliflozin as regard to the cardiac protection.
Doctor, in addition to that, what is the role of empagliflozin in heart failure as well?
I think it's a good question again because I was talking so much about the dapagliflozin in the protection of the heart failure because that trial came before that, and EMPA were not, they were not behind. They came with the many trials, role of empagliflozin in preserved ejection fraction, role of empagliflozin in reduced ejection fraction. So they told us that it's not only the mortality benefit or the 3-point MACE, they also showed benefit in terms of reducing the hospitalization for heart failure, particularly in patients of heart failure with reduced ejection fraction. Now they went further ahead. Now they started trial in patients with the preserved ejection fraction because they wanted to see, even with the patients with diabetes, which are having normal function of the ejection fraction, with whether this molecule is going to be helpful in preventing the heart failure later on. That also showed in the EMPA preserved trial that it is also helpful in reducing the hospitalization for the heart failure in patients with heart failure with preserved ejection fraction. But I will slightly differ a little bit in the sense that, when I saw the trial, the recruitment of the patient in the trial, there were some patients who were in the mid-range of the ejection fraction. They were not absolutely the preserved ejection fraction, some in the mid-range. So that might have skewed the statistics towards that it also helps in the preserved. But nonetheless, it has shown, even in the patient was having mid-range problem. Mid-range means when the preserved ejection fraction is above 60. 45 to 60 is the mid-range, less than 45 is the reduced ejection fraction. Because majority of patient recruited was in the mid-range ejection fraction, but still, I told nonetheless that it really helped in reducing the hospitalization of the heart failure later on, even in the patient, those who had preserved heart fraction or the preserved ejection fraction.
That is amazing, doctor. So we got to know empagliflozin demonstrated benefits in both heart failures with reduced ejection fraction
As well
and
as preserved.
ejection fraction. So now what I want to know from you is that how does this data compare to dapagliflozin's clinical studies in heart failures?
Right. If we see very closely, when the DAPA heart failure study came, they took the patient, those are not with a very high risk of the cardiovascular disease. Those are having what they call the multiple cardiac risk factors, but not the established cardiac disease, because their main focus was on the heart failure. Now with the empagliflozin coming with the heart failure studies, both in the reduced ejection fraction and the preserved ejection fraction, we are now thinking that there is an edge of empagliflozin over the dapagliflozin, because mechanism of action of protection of the heart theoretically is the same in all the class of the gliflozin. Whether it alters the myocardial energetics, the myocardial dynamics, and increases the myocardial oxygen consumption. But looking at the trial of the preserved ejection fraction, right now I will say that EMPA will be a preferred choice for me in patient right from the very beginning, when the patient comes to us from the day one, when the patient sees this normal ejection fraction, there is no problem in the heart. If you start giving this SGLT2 inhibitor like empagliflozin, you are able to give the protection, same holistic protection, CRF, cardiorenal metabolic protection. And that is why when the empagliflozin patent was finished, then there were so many other generics who came for the manufacturing of the empagliflozin, so that the maximum benefit can be given to the maximum number of patients, those who are not able to afford the drug because of the patent, and because the same company, the drug was at a high cost, now the drug cost has reduced considerably, so we can give the benefit of this particular molecule to millions of patients and give them the CRM approach of treatment of diabetes, cardio-renal metabolic protection.
Okay, so doctor, firstly, we saw the two MACE concept, but now we have a new vision with the third dimension entering with the three MACE concept, that is metabolism as well. So, getting again back to diabetes, how does both of these gliflozins compare to each other in reducing the HbA1c in type 2 diabetes patients?
I think when I started my discussion for the gliflozin, I said one sentence that as regard to the metabolic efficacy, in terms of the HbA1c reduction, I usually put all the gliflozin on the same board. That means their blood sugar lowering efficacy in terms of the reduction of the HbA1c is almost equal in all the three. So the CRM approach basically is important for the cardio and renal. Metabolic part, we know that all of the drugs, they will reduce the HbA1c with the same level of reduction HbA1c. But the main question comes about which is important in terms of the cardio-renal protection. So HbA1c, I won't say that the EMPA causes more reduction in the HbA1c as compared to the dapagliflozin. That depends at what level of entry of HbA1c you have started using this particular molecule. Higher the HbA1c, the greater the reduction in the HbA1c. Lower the HbA1c, lower the HbA1c reduction. So overall, they have all equal efficacy, all the gliflozins.
So, doctor, out of this whole conversation, what I'm getting right now is that empagliflozin is having somewhat of an edge to the other gliflozins like dapagliflozin, and it's economical also. So, are there any contraindications of prescribing it as well?
You know, any drug which we are giving to any diabetic patient has got some contraindications in certain subgroup of population. The first contraindication of using empagliflozin in diabetic patient is that when the patient is having acute genitourinary tract infection. Genitourinary tract infection means either the urine infection or the infection of the genital tract. Like in male, we call it balanitis. In female, we call it vulvovaginitis. If the patient is having active genital urinary tract infection, we should not be using SGLT2 inhibitor, number one. Pregnant females should not be given SGLT2 inhibitors. Type 1 diabetes should not be given SGLT2 inhibitor, though there has been some studies of using SGLT2 type 1, but that is out of box now in the sense that we are talking about the type 2 diabetes. Major infections, number one. Number two, in patients who are pregnant. And ultimately, I'll tell all my patients, whenever we are using an SGLT2 inhibitors, we should always think of whether the patient is not very cachectic, not very lean and thin, whether he is not sarcopenic, that he has lost muscle mass. But the moment you start giving SGLT2 in these patients, they will further lose weight. They further lose fat mass, and along with the fat mass, they will also lose the muscle mass, the sarcopenia. So these patients should be avoided giving the SGLT2 inhibitor. Otherwise, this is a pretty safe drug. Without any much concerns of the various side effects, this drug is pretty safe unless and until you educate your patient how to take, when to take, select your patient properly. So I think this is the best and the safest drug to treat diabetes and its complications.
So, doctor, the whole conversation was very insightful. But for me personally, what I found the most interesting part was that you were the first endocrinologist in New Delhi. That is amazing. And with 40 plus years of experience and legacy, what I want to know from your experience is that out of all these gliflozins, which would you personally recommend to prescribe, and any advice for the budding doctors for the treatment of diabetes, please?
I think with the science, what I have told you, and with all the evidence, what I have read, and with all my experience so far, what I think personally that if you know about the molecule, if you have read very clearly and precisely about the various trials and their benefits in cardio-renal metabolic protection. So whatever gathered the whole information, my experience, one must choose a drug which has got the least side effect profile. And I'm happy that I don't have to adjust the dose of the gliflozins, particularly the empagliflozin, even the GFR is very low. And number two, that we have a solid data, a solid evidence backing the efficacy of empagliflozin, not in terms of the cardiac protection. It also protects you from the heart failure. It also protects you from the progression of the diabetic kidney disease or the chronic kidney disease, and also causes a good improvement in the blood sugar pattern. And apart from these three CRM approach, the most important part of this gliflozin, they are the agents which causes the weight loss in a patient who is already overweight and obese. Because weight is the main consideration for the control of diabetes. And if a drug causes weight loss, it is always welcome. apart from the drug which are more potent but they cause weight gain. So we always welcome a drug which is what you call the weight loss, which protect the kidneys, which protect the heart, and has a very improved glycemic profile in terms of the HbA1c reduction. Obviously, that my experience, the literature experience, the evidence behind, and all the science will tell me that all right, AMPA is the drug. Everybody should use it. All the even budding endocrinologists. But don't forget that other drugs are you should throw into the dustbin. Have your brain. What kind of a patient, where you have to choose, which molecule you have to choose, where this really patient is good for that particular drug class of drugs. With that, I think I've given my knowledge and my share of my experience for all you docs regarding the suitability, rapid availability, and the indications, the contraindications, and the way you should use this molecule in your day-to-day clinical practice.
Thank you so much, Dr. S.K. Wangnoo. That was a very fruitful conversation that we got right now. We got to know about diabetes, its treatments, all the gliflozins, lots of knowledge. And I hope all the docs watching got some pretty good insights out of this conversation. This episode was pretty interesting. If you want to watch more such episodes, make sure to follow us on MNOM Talks and Diabetes Dialogue on Instagram, Facebook, Twitter, and YouTube. We'll see you on another episode. Thank you so much, Doctor. Thank you so much, all watching.
Thank you very much.
Thank you.